Okay.
So for all participants already logged in, we give it another minute to give people the chance to enter this webinar before we start. The numbers are still going up, so it looks very good. Okay, as numbers are stagnating, I think we can start the webinar. So from my side, and also on behalf of my co-moderator, Ihab Shiban, and the ENS spine section, I'd like to welcome you to this webinar of the ENS spine section, which is going to be the last webinar before we go into the summer break. And for this webinar, I'm very happy and I'm very proud to have a very important topic, which is going to be presented tonight, by very well-known presenters, which is Michael Fehlings from the University of Toronto, a neurosurgeon, and Brian Kwon from the University of Vancouver, who's an orthopedic surgeon. And they recently published a quite important paper or series of papers, which is published in the AO journal, and it's a actual guideline for the management of acute spinal cord injury. And this publication is separated into, I would say, about 3 different headlines, which is one, timing of decompression, the other one is management of hemodynamics in patients with spinal cord injury, and the third one is the management of intraoperative spinal cord injury. And I'm very happy to have those speakers here tonight, which are going to present their guidelines and their work, where they have a lot of co-authors. So just some housekeeping, as we usually do. We have the presentations first, which is going to be split in 4 presentations. And after the presentations, we're going to have a discussion, and please enter all your questions in the chat box or the Q&A box, and then we're going to discuss your questions, and I'm going to pass it on to the presenters. So that's it for now. Thank you, Michael. Thank you, Brian, for being here, for giving this presentation. And it's going to be Brian to start with the first presentation on the guidelines for acute spinal cord injury management. Brian.
All right, terrific. And thank you very much for that introduction. And thank you for making time for us to present our guidelines on behalf of Michael and myself, AO Spine, the Praxis Spinal Cord Institute here in Canada. We're very pleased to have this opportunity to share these guidelines and really talk about it, start to have a discussion about the implementation of these recommendations. So really appreciate the opportunity, and thank you all for in Europe for joining at the end of your day. And we're excited to present some of our work. I'm going to start with a bit of an introduction, and then, as Florian said, we're going to have discussions about the other guidelines that are in this focus issue that was published in March. But I'm going to just provide kind of an overview of the process and some of the background that went into undertaking this initiative. Some of this actually started from, and I want to highlight the guidelines that were done in 2017 that Michael Fehlings led on recommendations for traumatic spinal cord injury. And this covered 5 topics: the timing of decompression, the efficacy of methylprednisolone, anticoagulation, the MRI, and then rehab. And I point these out. These are published and available on the Global Spine Journal, but it introduced a very, I think, important methodology around how to do guidelines. And there is actually a way to evaluate the rigor and quality of guidelines. And we actually went through a process that was sponsored by Praxis back in 2019, just before the pandemic, where we graded all of the guidelines for spinal cord injury. And there are hundreds of them, not just in surgical management, but in bowel and bladder management, pain management, etc. And what emerged from that process were that the best and most rigorous guidelines were actually according to this instrument that grades the quality of guidelines, the top scoring guidelines were actually the AO Spine guidelines that Michael had led in 2017. So from a methodological standpoint, we really wanted to kind of utilize this methodology and go forward with a new set of guidelines that we just published. So we recognize that guidelines are living documents. They're meant to be revised and updated as new evidence emerges. And so it was not a unexpected thing that we would at some point take on an updating of these guidelines. So with that, we embarked on this process that was almost a 2.5-year process, sponsored by AO Spine and the Praxis Spinal Cord Institute. And really we wanted to tackle these 3 particular topics. So timing of surgical decompression. This was really an update from the last recommendations from the 2017 guidelines that I just spoke about. For hemodynamic management, the last recommendations were done almost over a decade ago from the AANS and CNS in 2013. And so we felt that there had been a lot that had been published in this space since then, and that this was worth revisiting. And finally, for the management of intraoperative spinal cord injury, this is really a new topic, but we felt was an important topic to begin to discuss. And all of us spine surgeons have these situations when you're faced with this situation of an intraoperative neurological decline, having guidance about what to do, we felt was important. So that was a new guideline that we tackled. And the overall overarching methodology was to utilize the GRADE framework to collect the scientific evidence in updated systematic reviews, and then utilize those through our guidelines development group and consensus meeting. And so that's the general structure by which the guidelines were generated. In summary, for timing of surgical decompression, some important work had emerged from after the 2017 guidelines, in particular this meta-analysis that Michael Fahlings led and was published in Lancet Neurology in 2022 or 2021. This was really, I think, an important thing that became apparent was necessary after the 2017 guidelines. And so we felt that it was time to update this topic. These were the 2013 guidelines on hemodynamic management from the AANS-CNS that recommended that MAP be maintained between 85 and 90 millimeters of mercury for the first 7 days. And we had previously done a systematic review in 2020 that revealed that really the relationship between mean arterial pressure and neurological outcome was uncertain, and that there was a lot that we probably could do and could update on these particular guidelines. And finally, the intraoperative spinal cord injury. I think we've all seen these kinds of images, and we all recognize the risk and the potential for neurological decline, and providing a guideline for the management of neurological or intraoperative spinal cord injury would be valuable for the field. So this was a multidisciplinary initiative that I was pleased to chair with Michael, and we had support from Nathan Ebenyu at the University of Calgary, Lindsay Tetrault in New York. It was, and I think one of the important methodological aspects of this is that we actually brought on a professional methodological core, aggregate analytics, led by Andrea Skelly. And this group this is a non-surgical group that undertook the systematic reviews and brought to that a lens of impartiality and professionalism around how to do the systematic reviews and really grade the quality of the evidence. And we had tremendous support from AO Spine, and Alessia was our project manager for this project. Now, this was, as I pointed out, a fairly extensive undertaking, and we had a systematic review committee, and then we had guidelines development subcommittees that were led by Nathan Ebenyu and Lindsay Tetrault, respectively. And I think one of the things to point out from a methodological standpoint is that by doing this within the grade framework, we really engaged people of multiple disciplines. So this was not solely a surgical guideline per se, that we involved individuals of orthopedic and neurosurgical background, obviously, but also intensive care physicians, anesthesiologists, nurses, neurologists, first responders. And importantly, we also included individuals living with spinal cord injury to include their voice in the recommendation generation. So it was truly a very multidisciplinary effort. We wanted it to be global with its representation. We took advantage of the fact that everybody was using Zoom at that stage when we undertook this. And we used the grade methodology for assessing the literature and then applied the evidence to decision framework of voting. And I think this bears some discussion because, most people, when you think about recommendations in the past, you think, well, what's the quality of evidence? How strong is the evidence out there for making a clinical decision and whatnot? And you can think about quality of evidence and, do we have good randomized controlled trials and whatnot? But in reality, when you think about it, this isn't actually how we clinicians think. We don't just think about the quality of the evidence. And when we actually are making decisions about patients, we think about things like, what are the pros and cons, and do they outweigh one another? What are the resources required? What's the incremental cost benefit? What would be the impact on health equity? Is the intervention that we're considering acceptable to the stakeholders, and is it even feasible to implement? And so the evidence to decision framework is actually aligned with the way that we kind of think about everyday clinical decision making. I think is an important part of the recommendation development. So it's not just, obviously the quality of the evidence that is out there is considered, but it's not the only thing that's considered. And the evidence to decision framework goes through all these questions, and the guidelines development committee reviews all of these questions in making the final recommendation. So with that, we embarked on these three topics. So timing of a surgical decompression, and Michael is going to speak on that next. I'm going to then follow with a discussion about the hemodynamic management guidelines. And then Michael will review the intraoperative spinal cord injury recommendations. And then finally, we'll end with some discussion. So that's the brief overview of what we embarked upon. And with that, I will stop sharing, and I'll turn that back over to Michael. Oh, you're muted, Michael.
Just to confirm that you can see my screen and hear me okay? Perfect. Thank you. Well, many thanks to the EANS for allowing us to disseminate this information. We really greatly appreciate this opportunity, and the dissemination of these guidelines and the discussion around the practical implementation of these guidelines is a very important element of this process. So I'll be kind of talking about the concept of time of spine and kind of the case for early surgical intervention in acute spinal cord injury. It needs to be emphasized at the outset that these are guidelines. They don't replace individual decision making on a case. There's a lot of personalization that is required for sure. No relevant disclosures, and I'll just talk about sort of the rationale to consider early surgery. I'll discuss the previous guidelines and then present some of the novel data that have informed a revisitation of these guidelines. And then I'll talk a little bit about a few of the knowledge gaps. I'll discuss some of the controversies around central cord injury. How does this apply to patients with ASIA A injuries, and then some conclusions and take-home messages. So if you consider about the constellation of the primary mechanical damage and then the secondary injury that evolves, there is a strong consideration around the idea that decompression of the injured spinal cord and stabilization of the unstable column can attenuate secondary injury. And in fact, this is supported by a wealth of basic science evidence. The Staskis trial, which is now reported over a decade ago, was really the first multi-center trial to point us in the direction that early surgery could improve outcomes. And this was a study through the Spine Trauma Study Group, 6 centers in North America, 313 patients with cervical spinal cord injury. We showed that early surgery could be done safely, and there was a very significant neurologic improvement with surgery done within 24 hours, as measured by a 2 or more grade change in the age impairment scale. And the odds ratio was almost 3-fold higher. And so this really had a big impact, I think, in the way clinicians thought about spinal cord injury, and I think really was a motivating factor toward consideration of early surgery. So based on this and a small number of other studies, in 2017, for the first time, we were able to issue a guideline that early surgery done within the first 24 hours was a preferred management approach. But the rigor of the grade process is such that we were really only able to offer this as an option, and the quality of the evidence was felt to be lower than I would have liked, and largely because it was just a small number of studies and we were unable to do a quantitative meta-analysis. So this really was a stimulus for a number of individuals in the field, including ourselves, to do further work. And this was a study that Brian alluded to. This was published in the Lancet Neurology in 2021. This was a study in over 1,500 patients with all severities of spinal cord injury. And these are 2 of the figures from this paper. Here on the left, we're plotting the changes in the motor score as a function of time after surgery. The red line is 24 hours, and we see a dose-response relationship with improved neurologic outcomes seen if you do surgery within this 24-hour time frame. This is a histogram showing the changes in the motor scores as a function of time. And again, the biggest improvements in function cluster in patients who are operated on within 24 hours. So if we then consider the evidence in total, in contrast to 2017 guidelines, where we had only 5 studies, including Staskis, for the new systematic reviews and updated guidelines, we had 21 studies that we had identified. And this then prompted a revisitation of this topic, new systematic reviews, and a new guidelines process. So if we now look at the recovery of 2 or more ASIA grades, we are now able to undertake a quantitative meta-analysis. And these are the 6-month and 12-month follow-up data. And the diamonds represent the mean and 95% confidence intervals. And this is a logarithmic scale, and this essentially replicates the Staskis data. We see that there's about a 2 to 3-fold increase in the odds ratio of having a 2 or more grade change in the Asia impairment scale with surgery done within 24 hours. So very large changes and quite consistent effects. Here are the changes in the motor scores, and we see here that, again, a clear signal favoring early surgery, and on average about a 4.5 motor improvement. We also see that surgery is safe. There was no increase in complications, and in fact, there was a trend in many outcomes for improved outcomes. So this is looking at the rates of mortality. We see it crosses the 0 line, so it was not significantly improved, but there was certainly a very interesting trend to reduce mortality with early surgical intervention. So based on this, a guideline has emerged with a strong recommendation that surgical decompression for acute traumatic spinal cord injury should be completed within 24 hours after injury. Now, here's the important caveat: when medically feasible, and there's still considerable judgment that's required. So, for example, in older patients, medically frail patients, patients with a milder, say, central cord injury, there's a lot of judgment that's required, and you may not always want to be able to or can take these patients within 24 hours. Now, what about this concept of ultra early surgery? And there's nothing magical about this 24-hour time frame. Time is fine, but the 24-hour time frame was one that was felt to be biologically rational, but also clinically feasible. Now, ultra early surgery, which we've defined as less than 12 hours, makes biological sense. And there is emerging literature support. So, for example, this paper from the San Francisco group suggesting improved outcomes with earlier surgical intervention. Again, referring to our Lancet paper, we see that there's a dose-response relationship between the timing of surgical intervention and improvement in recovery. And I want to thank the reviewers who prompted us to do this analysis when we were going through the review process at the Lancet. So I want to make reference to this study that came out of Europe, and we do reference this study in our systematic reviews and guidelines. And this is the SkyPlum study. Now, importantly, these authors looked at a comparison of ultra early surgery, less than 12 hours, versus later surgical timeframes. But one of the challenges that the authors ran into was that there was a shift in clinical practice that occurred in Europe as well over the course of the study. And the majority of the patients in the delayed group were actually operated on within 24 hours. And so the distinction between ultra early and later was less clear. Now, importantly, on the unadjusted analysis, there was a significant trend for improved recovery in the ultra early group. It did not meet statistical significance. And then there were some baseline differences that the authors had some challenges in terms of trying to adjust, and there was some loss of follow-up. But certainly I would say that while not definitive, the study does suggest a signal for the potential role of ultra early surgery. So it makes biological sense. But because of some of the inconsistencies in the literature, we were unable to make a clear recommendation on the question of ultra early surgery. So this represents a knowledge gap, and I think going forward, potentially with a meta-analysis of some of the existing studies, perhaps with further studies, we'll be able to clarify this issue. Now, what about the Asia A patients? And even when patients don't convert their Asia a grade, and about 40% of patients with an Asia A cervical injury will convert their Asia grade. But what about the other patients who don't? And this is some nice work from Valerie Terwengel's PhD thesis. These data indicated that early surgery within 24 hours was associated with a higher rate of gain of 2 or more motor levels. And this is really important in patients with a cervical injury. So, for example, if you think about, say, somebody who has a C5 or C6 level, if they recover, say, 2 or more myotomes, they can get hand and upper extremity function improve, which has a big impact on independence. And then what about the special consideration of traumatic central cord injury? And I would argue that this is really a form of an incomplete cervical injury. And, you know, patients with milder forms of injury, that you may think a bit about this and whether surgery might or might not be beneficial. But for more severe types of injury, I would suggest that when medically feasible, you should be considering early surgery. There's a 50-year-old woman with a low velocity fall. She has significant OPLL and she's contused her cord. She's presenting with an Asia C injury. And central cord injury is becoming quite important. And we see with that with the aging population, that the global burden of traumatic brain spinal cord injury is continuing to be an important issue. But we're starting to see a shift in the demographics of injuries where we're seeing older patients, more fall mechanisms, and more cervical injuries. These also present other challenges as well, so that there's a lot of decision making that we need to consider in older patients where there's medical frailty, and the challenge of central cord injury is emerging. Now, we tried to add some evidence to this field in this article published in JAMA Surgery. And this was a prospective propensity matched cohort control study. 186 patients with central cord injury, 93 patients had early surgery, 93 delayed surgery. And overall, we found that there was overall a beneficial effect of earlier surgical intervention if we look at the upper extremity motor scores. But when you parse this out, the biggest effects were seen in the patients with more severe injury, the Asia grade C patients. And the effects were less clear for the milder injuries, Asia D. Now, that doesn't necessarily mean that surgery doesn't have a role in these patients. I think it likely does. but we need to have improved outcome measures in these milder patients. And so, for example, we need to be evaluating hand function, pain, spasticity, and so on. But certainly, when medically feasible, you should be contemplating the option of early surgical intervention in more severe ASIA-C central cord injuries. And also the technique matters. So the extent of decompression matters, and as well as the timing of intervention is highlighted by this important work by Bijan Arabi. And I just wanted to also highlight some work out of the UK by Marius Papadopoulos and colleagues. And this group has undertaken a randomized trial to examine the question of whether an expansile duroplasty might enhance outcomes after a traumatic spinal cord injury. So take-home messages in future directions: surgical decompression for cervical and thoracic spinal cord injury within 24 hours after acute SCI improves neurologic recovery. And the current guidelines do offer a clear recommendation that when medically feasible, early surgery should be undertaken regardless of level. But there's nothing magic about the 24-hour cutoff, and I would argue that time of spine matters. So in a young person without medical comorbidities, I think ultra-early surgery makes sense, especially for an incomplete cervical injury. So on that note, I'll stop screen sharing and hand back over to Brian to talk to us about the recommendations related to hemodynamic management.
Terrific. That's great, Michael. Thanks very much. Okay. I think, does that show up in everybody's screens? So always a tough act to follow. Thank you for that, Michael. And I'm going to take over and talk about hemodynamic management. This is a new guideline recommendation that we've made. I'm going to sort of review where we started, what we actually considered in the generation of these guidelines, and then what did we eventually vote upon. So as I referred to in the introduction, we began with the 2013 AA and S CNS guidelines, and I think we recognize these were widely acknowledged. We ourselves were very strong adherents to this guideline, and it recommended that hypotension be corrected and that the mean arterial blood pressure be maintained between 85 and 90 millimeters for the first 7 days. Now, the concluding paragraph of this guideline, if you actually read the entire guideline, included this paragraph: key issues for future investigation, and that is the issue of whether blood pressure augmentation has impact on outcome is important and deserves further study. And if augmentation of MAP is determined to be a benefit, the most appropriate threshold of MAP and the length of augmentation need to be defined. So it was even recognized back in 2013 when these guidelines were published that this was actually an area of future study, that so a MAP target and a duration were recommended, but the guideline did acknowledge that there was this knowledge gap about what the optimal target ought to be. Now, we undertook a systematic review in 2020 with Nathan Avenue and concluded that really, if you look at the literature very closely and subject it to a really rigorous assessment of the quality of evidence, we concluded that really it was low or very low quality evidence that the effect of MAP support on neurological recovery after acute traumatic spinal cord injury was uncertain. And so we embarked on a new revised systematic review as part of the guidelines process. And so this was an updated systematic review. This is published now. And the key questions were: what were the effects of interventions to optimize spinal cord perfusion? And what are the effects of particular monitoring techniques, ranges, pharmacological agents, durations of treatment, on the extent of neurological recovery and rates of adverse events? So those are the key questions that went into the systematic review. This was the list of papers that were actually reviewed. And in summary, we had 28 studies, 1 randomized control trial, 27 observational studies, and this included many of the studies that we had reviewed in the 2020 systematic review, but also included 9 subsequent papers that had been published in the meantime. Now, as Michael alluded to, some of the work from Marius Papadopoulos, for the neurosurgical community, obviously the relationship between cerebral perfusion pressure, intracranial pressure, mean arterial pressure is well understood. The same relationship physiologically exists within the spinal cord, and we typically don't measure the spinal cord perfusion pressure, but can be measured either with a pressure monitor at the injury site or with a lumbar intrathecal catheter, as Marius Papadopoulos has been doing. And so we looked at these two areas of MAP augmentation or MAP support and spinal cord perfusion pressure support. And these were the studies that were included and the participants that were included. And in summary, I just kind of want to bring your attention to the right column, the quality of the evidence that was assessed using the grade methodology. And really across the board, and this is where, it's sometimes a very humbling thing to see your own papers get evaluated according to the grade methodology, because it's a very rigorous way of looking at the literature, and sometimes your own studies can be graded as very low quality evidence. But across the board, the quality of the evidence was considered to be very low. So the effect of MAP support or spinal cord perfusion pressure support on neurological recovery is uncertain, and the quality of the evidence was deemed to be universally very low. As to the second question about, what about different techniques? What about different ranges? What about the choice of vasopressor? What about the duration of treatment? Again, these are all questions that are important, and again, the quality of the evidence was deemed to be very low. So the bottom line really is that we recognized that the relationship between the MAP targets on neurological support was uncertain, and there's emerging evidence that spinal cord perfusion pressure may be associated with improved neurological recovery, and that there really wasn't very reliable guidance around, the monitoring techniques, the perfusion ranges, what pharmacological agent you should choose, or really even how long one should treat for. So these were all things that we kind of recognized going in. So we elected to undertake this process where we asked for the guidelines development this question of, well, okay, if we're going to try to implement a MAP-directed goal, what should there be as a lower limit for that MAP, and what should there be as an upper limit for that MAP to optimize spinal cord perfusion? And so we went back to the literature and looked at all the papers in the systematic review that actually described a lower limit of MAP in their patient cohort, and what that lower limit of MAP's influence was on neurological outcome. And as you can see from this chart, really, this is a summary table, but in some cases there was actually no lower limit actually even identified as a lower limit below which neurological recovery was worse. And so, in summary, really, people had published a lower limit range of anywhere between 70 to 85. Some studies indicating no lower limit at all. So we put this to the group and the guidelines development group to vote about, okay, well, what do you think would be a reasonable kind of lower limit for the MAP based on this existing literature? And the guidelines group kind of voted that that range be somewhere between 75 and 80 millimeters of mercury at the lower limit. So then we turned our attention to the upper limit. So what does the evidence point to for the upper limit? So what are papers? What does the published literature talk about in terms of what happens to neurological recovery if you exceed a certain limit with vasopressors and whatnot? And this is what that data looked like. These are the papers that described either neurological recovery over certain MAP targets, and then adverse events. We all recognize that there are adverse events associated with aggressive vasopressor usage. So these were some of the papers that described complications and adverse events related to the use of vasopressors for MAP augmentation. So the bottom line summary from this is that vasopressors can be associated with adverse events, and I think most of us recognize that, and that the data really, there were papers that describe no real benefit beyond an upper limit of 95 millimeters of mercury. So again, we put that question to the guidelines development group and asked, what should the upper limit for the MAP target be? And we voted that it should be somewhere in the 90 to 95 range. So this was the question that then went through the evidence to decision framework. So should we recommend the implementation of a MAP-directed goal with the lower limit of 75 to 80, as we voted on, and the upper limit of 90 to 95 at the upper end to optimize spinal cord perfusion? And I made reference to this evidence to decision framework, which sounds complicated, but as I pointed out in the intro, it's in some respects kind of intuitive about the way I think we normally think about clinical decision making. So weighing the benefits and harms, looking not just at the quality evidence, but what's the cost associated with it, the resource allocations, the acceptability and feasibility. So with that, after subjecting this question to all of those considerations, the guidelines development group came up with this final recommendation that we suggest the augmentation of mean arterial pressure to at least 75 to 80 millimeters on the lower end, but not higher than 90 to 95 millimeters mercury in the upper end to optimize spinal cord perfusion pressure. Recognizing that the quality evidence was very low and making this a weak recommendation, because it's hard to have a very strong recommendation, no matter what people think, if the quality of evidence is acknowledged to be low at the outset. The next question was really around duration. So if we're going to set these MAP targets, how long should we do this in the acutely injured patient? So what does the evidence point to? This was the systematic review. These are all the papers that described a duration of hemodynamic management. And again, a busy table, but really the summary is that if you look at the duration of therapy, it was really all over the board. So some reported as long as 7 days, but other studies were as short as even the intraoperative period. So it really represented a range. And it's interesting, I think if people think, well, there's a lot of evidence around the 7-day MAP augmentation. In fact, this is the list of papers, and the duration was really quite variable. So again, we put this question to the guidelines development group. What should the duration of MAP management be based on the available evidence? And the vote was really kind of ranging between 3 days to 7 days. And I think that probably reflected, I think the reality for many surgeons that it's sometimes hard to keep somebody in the intensive care unit for a full 7 days for hemodynamic management. So again, this was the question that then was put through the evidence to decision framework. Should we recommend the implementation of a MAP-directed goal for a duration of 3 to 7 days? And the recommendation that emerged after going through all of those considerations in the evidence to decision framework was that we suggest the augmentation of mean arterial pressure for a duration of 3 to 7 days in order to optimize spinal cord perfusion. Again, recognizing that the quality of evidence was very low, the strength of this recommendation was weak. Finally, should we recommend the use of a specific vasopressor in order to achieve that MAP-directed goal? We looked to the literature. There really was not a lot of literature to guide us in this regard, and so we felt that this is a decision that really should be left to the clinician in terms of how they want to go about augmenting the mean arterial pressure. So that was the guideline recommendation. We suggest a MAP target from 75 to 80 millimeters of mercury at the low end and 90 to 95 at the upper end for 3 to 7 days, with the choice of vasopressor being left to the clinician. Now, I want to address a very important point that, we have to acknowledge that the literature itself around the MAP targets has its limitations, and to some extent, this putting in this range kind of recognizes that. And that the guidelines do reflect the sentiment that, of all things, hypotension should probably be avoided, but that there's something potentially deleterious as well about aggressively pushing the MAP way up beyond 95 millimeters of mercury, either from the systemic effects of vasopressors or potentially even for the cord itself. Now, one of the questions that we knew would arise from this guideline is, what is with this range? What is with this range, and why did we decide on like a 75 to 80 at the bottom end to this 90 to 95 at the upper end? And we actually wrote an entire paragraph in the guidelines to kind of explain this. But in essence, I think figuratively, this is actually what we were trying to achieve. We know that, it's not super straightforward to just titrate in a specific map with vasopressors, and we know that people bounce around, and this is something that is not always easy to just dial in a vasopressor dosage and keep somebody's map at a certain level. So we know that if you have, for example, on the left, a range of 75 to 80 at the bottom end, 90 to 95 at the upper end, then of course, hopefully with map management, you'll be getting map targets that are kind of in the zone. But then you might have a map that falls a little bit low into this lower end. And that is sort of the signal that, okay, well, maybe we need to kind of increase the vasopressors and bring them kind of up out of that zone. Similarly, if you fall into the upper zone where you start to see maps in this, oh, we're into the 90 to 95 zone, well, that then gives you the signal to try to bring it down. The converse, though, is to just have this, well, why not just set it to 75 at the low end and 95 at the upper end? What we think would probably happen in that situation is that it's inevitable that you kind of are in this range, but then it's easy to, oh, all of a sudden now we're above it. Oh, okay, now we have to respond, but now we've actually had the patient above 95, and now we're trying to fight to bring it down. And at the other end, that, oh, well, we brought the patient's map down, but oh, now we've actually fallen below it, and now we're responding. And so part of what the guideline tries to kind of encapsulate is that we're trying to actually avoid these upper extremes, the upper extremes of hypertension, the lower extremes of hypotension. And that's one of the reasons why we thought having a range of sort of 5 millimeters of mercury at the upper end and the bottom end would provide guidance for clinicians to say, to try to keep people more in that middle range of the map target. So we think that these extremes ought to be avoided. And we've kind of acknowledged that it's not always easy to just titrate in a map and keep somebody at that level. So at the end of the day, the map target is a weak recommendation. We seek to avoid hypertension and hypotension. It does lead to the question of what should we actually be doing? And I get this question in our own institution. And so this is kind of what I do. And this is really just to say that, I wouldn't necessarily say this is how everybody needs to do it, but this is kind of how we've implemented it locally. I think in severe ASIA A and B patients, keeping them in this 80 to 90 millimeter range for the full 7 days is, I think, appropriate. We have data that suggests that this ischemic change within the cord doesn't end at 7 days anyway. So I think that keeping them for the full 7 days, I think, is reasonable. But in less severe individuals with C and D injuries, I think keeping them in this range for a shorter duration, and many times they're already at this range on their own without any vasopressor support. So I think it's sort of sensible that giving a bit more discretion to keeping them in the ICU for a shorter period of time is reasonable. We typically use norepinephrine over phenylephrine or dopamine. So at the end of the day, we publish these guidelines. We recognize that there is more evidence that is required to ultimately delineate the effect of MAP support on neurological recovery, and that at the end of the day, ultimately, we do need something to monitor the injury site to help us understand how these hemodynamic management approaches are actually affecting the spinal cord. So with that, I will turn it back over to Michael for the discussion about intraoperative spinal cord injury.
Thank you, Brian. So I'm going to close out by kind of talking about an area, that causes a lot of stress for, all of us when you're doing higher risk cases. And, how do you prevent and treat a situation where, a patient declines intraoperatively? So I'll just kind of talk a little bit about framing the question, present some of the evidence around intraoperative neuromonitoring, and then really, I think, recognize that this is really kind of a stimulus, I think, to acquire further evidence going forward, but we suggest a potential care pathway that people might want to implement. So we sought to define intraoperative spinal cord injury, to try to categorize cases that would be at higher risk, and to try to assess the sensitivity, specificity, accuracy of intraoperative neuromonitoring, and then to try to develop these evidence-based care pathways. So just by way of case example, this is a patient in my own practice, a patient who has this nodular enhancing intramedullary tumor consistent with hemangioblastoma associated with a tremendous amount of AV shunting and syrinx formation. So this presents a significant challenge related to microsurgical resection, and I'll come back to how we managed this case. So we've used a mixed methods approach for a number of topics. A rigorous meta-analysis was possible. In other areas, a more of a scoping review was undertaken, and we again used the grade process. And again, just by way of summary, in the traditional way to generate guidelines, randomized trials result in a high level of recommendation, observational studies in a lower level of recommendation. But in grade, we don't just look at the quality of the evidence, we also look at the balance between benefits, harms, and burdens, patient preferences, and also issues related to feasibility and resource use. So we defined an intraoperative spinal cord injury as a new or worsening neurological deficit attributable to spinal cord dysfunction during spine surgery. It's diagnosed intraoperatively by a neurophysiologic monitoring and or a wake-up test, or immediately post-operatively based on clinical assessment. And the best data arise from intramedullary tumor surgery, where the risks are higher, as well as a more complex deformity surgery. So this is a proposed table. This is not set in stone, and this is up to the individual clinician to consider. But certain high-risk patients for intraoperative spinal cord injury, patients with complex spinal deformities that have a high deformity angular ratio, patients who have congenital deformities with significant cord compression, intramedullary tumors, certain unstable spine fractures, particularly with ankylosing spondylitis. We felt that OPLL with severe cord compression represented another specific instance. So we were able to generate a very quantitative meta-analyses in over 100,000 patients that undergone neuromonitoring related to the diagnosis of intraoperative spinal cord injury. This just shows the forest plots of sensitivity and specificity. And the bottom line is that multimodality monitoring has about a 91% sensitivity and about a 95% specificity. So it's not perfect, but it's quite good. And we used a random effects model, and there's some data for those that are interested in methodological approaches to confirm these results. So the first key question was, should we recommend intraoperative neuromonitoring for patients undergoing spine surgery deemed by the clinician to be at higher risk? And the bottom line is that we recommend this. And although the quality of the evidence was felt to be low, despite the large number of patients, it was felt that there was really a very strong signal, and the guidelines development group felt that this was a strong recommendation. Now, what about different management of approaches? And here we've adopted the intraoperative checklist for the management of intraoperative neuromonitoring signal changes from Vitali et al., published in the Spine Deformity Journal. And there are surgical factors to look at: taking a pause, avoiding external distractions, and then perhaps considering what was the cause. So it was a screw positioning, a correction of the deformity, so perhaps release of that deformity, correction, considering neurophysiological and technical factors and anesthetic systemic factors, so the mean arterial blood pressure, considering the use of intraoperative corticosteroids or other adjuncts. So the second key question was, should we recommend that patients deemed to be at high risk for intraoperative spinal cord injury, should these people be proactively identified? And then should there be some multidisciplinary team discussions, and should there be some kind of an intraoperative protocol in place? And it was felt that yes, this sounds like a good idea, this is recommended, but the quality of the evidence is very low, and hence the strength of the recommendation is weak. And I think this represents an opportunity going forward over the next several years to try to validate these approaches and then hopefully to generate higher quality evidence. So we've developed an intraoperative checklist, which is briefly summarized here. This involves an initial clinical assessment, so careful, informed discussion, shared decision-making with the patient, then preoperative planning, including multidisciplinary team discussions and making sure that you have all the appropriate adjuncts in place, surgical anesthetic planning, so including, for example, the maintenance of mean arterial blood pressure targets, having arrangements when available for neurophysiologic monitoring, the intraoperative management, so then having a checklist in place if there are intraoperative neuromonitoring changes, and then the postoperative management should such an issue occur, so having a monitored bed, consideration of the use of postoperative imaging, maintenance of MAP parameters, and potentially the options for pharmacological adjuncts such as corticosteroids or for example, riluzole. So in terms of the management of this case, it was felt that this was a higher risk case. It was a fully informed discussion. There was multidisciplinary team discussion. We had multimodality electrophysiologic monitoring in place. We actually started the patient preoperatively on corticosteroids, and we had advanced nursing care available postoperatively. So intraoperatively, these are some photomicrographs. Here's the dura opened. This is the lesion here, right in the vicinity of the corticospinal tract. It's a hemangioblastoma. So here we're doing a subfield dissection with a resection of the lesion. And then during the resection of the lesion, there was a reduction unilaterally in the arm motor revolt potential response. And the approach here was to take a surgical pause, make sure the mean arterial pressures were at an appropriate level, do the dissection in a different area, come back to that previous area, and ultimately we were able to achieve a complete tumor resection, and the patient awoke with an excellent neurological status. So the key next steps are those related to knowledge translation, implementation. So we're hoping that people will consider the adoption of the proposed AO spine praxis care pathway and perhaps modify this and validate this through prospective studies. I think there is a need to develop and validate neuroprotective strategies to mitigate intraoperative spinal cord injury. And I think we recognize that there are challenges in certain areas of the world. Even where I work in Canada, not all hospitals have intraoperative neuromonitoring available. So methods to look at the wider adoption and availability of intraoperative neuromonitoring. And in conclusion, so this is the first evidence-based comprehensive guideline and care pathway for the prevention, diagnosis, and management of intraoperative spinal cord injury using graded methodology. We hope that this work will facilitate a reduction in the incidence of intraoperative spinal cord injury and improved outcomes from this complication. We welcome the wide implementation and validation of these guidelines in care pathways in prospective multi-center studies. And on that note, I'll close. Happy to open this up for discussion. And again, many thanks to the EANS and EANS leadership reflected on this webinar to allow us to present this work.
Well, great. Thank you, Michael. Thank you, Brian, for these excellent and very important presentations. I think this is, we all know this is a topic of ongoing debate and insecurities and different opinions. And I think putting this together once again is very important. So for the participants, we have some time left for discussion. So whenever you have a question, please type it in the Q&A box. Maybe you can type it in briefly, as I see there long text is coming up. But then I'm going to pass on the questions to both presenters. But I'd like to take the advantage to start with one question. Just going in the sequence of the presentations, when we talk about timing of decompression as the first point, how do you translate this, the knowledge we have currently to your own practice regarding ultra early decompression? How do you select patients for ultra early decompression, as we think biology and the whole concept makes sense to go for ultra early decompression? what do you do in your own practice? How do you select patients, and for which patient does it make even more sense, and is it even more important than for maybe other patients?
Well, maybe I'll start, but like, I think it's important to recognize that over the course of my career, Toronto has gone from being a center of non-operative management of spinal cord injury to where, the surgical management is a core principle. So there's been a really significant change, which initially in my career was quite controversial and difficult. So there's tremendous judgment that's required. And I want to emphasize again, because I know this has ruffled some feathers around, okay, does everyone need to go to the operating room early, and what about older patients? So there's a lot of judgment that's required. And these guidelines don't replace that judgment. But let's say talk about a young person who's medically well. This begins with systems issues. So in Ontario, we've implemented what's called a critical system, where physicians can contact the specialist through a 1-800 number. The image is available on the internet. And even though Ontario is a huge province, larger than France and Spain, we can implement very rapid transport. And so these patients are highly prioritized. And in the hospital, these patients are now done as a level A case. They're done, immediately. We have rapid sequence MRs. We get the imaging done en route to the operating theater, and we really have worked hard in a multidisciplinary fashion to make this work. And you really need to have buy-in from everyone. But again, I want to be very careful to emphasize that older and frail patients with a milder central cord injury, may not necessarily always be feasible. But also I want to emphasize that time is spine. If I've got a young patient with an acute spinal cord injury, we go for it. And patients who are older and frailer, and we may take a pause and think about medically stabilizing that kind of a patient.
Okay, thank you. Yeah.
And I think that, I would just add to that. I think having systems in place, I think, makes a huge difference. There was a question about, whether surgery is beneficial for central cord patients, and I think that, in some respects, if you really step back and think about what it is that we're trying to do, it's probably actually the patient population that surgery would benefit the most. That's one of the kind of the crazy things about the whole philosophy of like letting central cord patients just sort of sit and watch them as their cord kind of cools off. If you think about the biology of what the actual injury is, it's a lower mechanism injury. There's probably a significant ischemic component to the tightly compressed cord. And so if there is actually a biological phenomenon that would improve, or a biological case that would improve, it's actually probably the central cord patient. So I think that, and Michael has made this point many times, that starting to shift the thinking about central cord towards like these are patients that probably would benefit from surgery, and they would probably benefit from surgery early. And in some respects, having an individual with a low energy injury with an ASIA injury versus somebody who, has a high speed fracture dislocation of their cervical spinal cord, wrapping their car around a telephone pole at 100 miles an hour. I think probably the potential for neurological benefit may actually be in the former patient, right? Where you have this, very important ischemic compressive component to their pathophysiology. So I do think that it's important that we start to think maybe differently about central cord injury, and that these are individuals, and I think some of the data that Michael has published, these are individuals that may benefit from early surgery. Understanding the caveats that these are also individuals that are older and maybe have more medical comorbidities, and so there is considerations around how stable an individual like that is for undertaking an operation. But I think that it's a bit of a mindset shift that I think that we need to start considering.
Yeah.
Great. Thank you both very much. Again, Michael, your talks are, really the best on the topic. Brian, I really enjoyed your talk. I have two-part questions. Maybe for Brian, you didn't talk about riluzole as a medical treatment post-operatively. Do we know, would you like to recommend it like Michael's studies showed us. That would be part one. Part two would be for Michael. For the post-operative management, we now know from aortic surgery that they do prophylactic lumbar drain. Do you use that? Do you think it's a good option, or should we just wait for more evidence?
Maybe I'll reverse it. And
Yeah, I
ask
was going to say, let's reverse that.
I'll comment on
Really well, Michael.
comment on the drain. I'll talk about the riluzole.
Yeah. Why don't you go ahead with riluzole?
Oh, okay. So I realize we're short on time. We actually just published in JAMA Network Open a reanalysis of the CSM Protect trial, where it was a randomized trial looking at riluzole perioperatively for patients with cervical myelopathy. And using a global outcome assessment, we showed that there was a clear benefit of riluzole in the patients. And we have new data coming out actually to suggest that it reduces C5 palsies and reduces some certain neurologic issues. We have a similar reanalysis doing for the Riscus trial. So the Riscus trial, we missed the primary endpoint. We saw some interesting results on the secondary endpoint. So I would say it's an option to use. The risk-benefit ratio is really good. It's really super safe medication to use. So I would say, like, why not use it? And so we actually are increasingly using it as Intraoperative. But it's an option. Like, it's not a standard of care, but I think it's something that you might want to consider using in your practice.
Great, thanks.
Yeah, and for lumbar drainage, something that we've had a lot of interest in. We've had in our ongoing clinical trial almost 60 patients that we've been doing lumbar intrathecal catheter insertions and CSF drainage. And I think that one of the things we're learning from that is that it's not as straightforward as the thoracoabdominal aortic aneurysm patients. And probably this has a lot to do with the fact that, in the aortic aneurysm patients, the subarachnoid space around the spinal cord is open. And in the traumatic spinal cord injury patients, that subarachnoid space can be closed or occluded either by extradural compression from the bone or whatnot, or intradural compression by the swelling of the spinal cord. And I think this is an important kind of caveat around the use of lumbar intrathecal catheters in the management of spinal cord perfusion pressure. So I think that there's definitely interest in, and there is something to being able to drain CSF in these patients. And but I think that it's what we've learned is it's not as straightforward as I think the thoracoabdominal aortic aneurysm cohort, in which it's certainly in many centers is a fairly routine approach to put in a catheter and drain CSF. So we're doing some analysis of our data, but I think that's one of the things that I think one of the take-home messages is that there's probably some benefit to that, but it requires some thoughtfulness around surgical technique and around what is happening at the injury site for that to be really applicable.
Great, thank you.
Thank you. As we've been talking about pharmacological treatment or pharmacological neuroprotection, of course, we have in the QA box the question for the present role of steroids, corticosteroids, how you use it, which patients, and what role does it have currently in spinal cord injury treatment?
As we indicated in the 2017 guidelines, it's an option. There are effects that are seen in the meta-analysis. The concerns always were kind of around the risk. The reality, though, is that with modern medical management, the risk of complications of corticosteroids are really low and can be managed quite readily. So I would say it's an option. We're using it in kind of younger patients with a traumatic spinal cord injury. The effects of any of these neuroprotective drugs are going to be modest, right? Like, we have to be realistic. And I would certainly say that, let's say if you've got a spinal cord tumor patient, high risk, like I presented, or a really tricky deformity case or something and say you run into some trouble, I would certainly, use corticosteroids. Whether you use dexamethasone or whether you're comfortable using high-dose methylprednisolone, I think kind of partly depends on your own kind of comfort level. We would tend to use higher dose methylprednisolone, but that's kind of at the option level. So I would say that it's a valid option.
Do you think it makes a difference in the case you just mentioned, in the tumor case where you give it prior to the injury, and in a real trauma case where you can give it only after the injury, whether this makes a big difference or whether some hours in between does not contribute to a completely different effect of steroids?
I think it makes a difference. Look, and we're aware of this. We see this all the time. In patients, say with a tumor, with peritumoral edema, you reduce the edema. Sometimes there's an improvement. I mean, it makes sense, right? We know this, that if you can pre-treat, we don't have that luxury. In a patient coming in with a spinal cord, the spinal cord injury, and the time window is relatively narrow to see a beneficial effect. So I would say in the setting of spinal cord injury, it's an option. I'm quite aware that many centers don't use it. It's not used as commonly in Canada as maybe elsewhere. We still use it in my unit in Toronto. I would say, though, that in terms of the medical complications, we have data that's coming out right now. I would say that with modern medical management 2024, the reality is we're very good at managing the complications related to corticosteroids. So I think from that perspective, you can administer them quite safely.
Okay, thank you. Enrico.
So, hi, Michael, and congratulations to Brian for the very inspiring presentation. And then I do have a question to both of you, because there are some few reports about the expansive duroplasty done for severe cord edema. I don't know if you have experience on it, and I don't. I never performed, so I've seen some few studies, and this is my first question. The second is about the intraoperative spinal cord injury, and you were mentioning the risk factors for developing a new neurological deficit. Very important slide. And do you use, Michael, intraoperative bolus of cortisone? So this is quite well administered very quickly, and I mean, we don't know what to do in most of the cases, but you made a checklist, and but do you administer a bolus of cortisone whenever you realize that there is an intraoperative spinal cord injury?
Maybe Brian, you handle the duroplasty, and then I'll handle the intraoperative SCI.
Sure. Yeah, and I think it's a great question, Enrico. And I think what the question of duroplasty really stems to this issue of, can you achieve a patent subarachnoid space around the injured spinal cord? And this is a concept that, I think, Maris Papadopoulos obviously talked about this, the concept of the spinal cord swelling, pushing up against the dura, and then causing this intradural compression of the cord. I think that one of the really important papers that is being published on this topic has come from Bijan Arabi, where he routinely does postoperative MRIs on his patients. And Bijan has this concept that, like, if on the postoperative MRI you see that subarachnoid space fully around the spinal cord, then that represents a complete decompression. And if you don't, if there's still this ongoing kind of, touching of the spinal cord against the dura, then it represents a, quote, incomplete decompression. And what Bijan showed in 185 patients, in which the Asia A and B patients, where they did pre and postoperative MRIs, is that doing a ventral decompression alone achieves this complete subarachnoid space patency in only about 50% of the cases. But that if you add a laminectomy posteriorly, you increase the chances that you'll get that complete decompression, such that if you do like a 4 or 5 level laminectomy, you get that complete decompression in almost 95 to 100% of the cases. Now, in a series, there are still patients in which even you do a large laminectomy, there is this swelling of the spinal cord that brushes up against the dura. But that turned out to only be 7 cases out of the 185. So, and the point that I think Bijan makes very nicely in his paper, and that we've certainly seen, is that really, if you're thoughtful about like the levels of decompression, and you do a posterior laminectomy with standard surgical techniques, you can actually get this patent subarachnoid space in the majority of cases. And so, and in which case you don't necessarily even need to do a duroplasty. And I think using intraoperative ultrasound is an excellent way of actually assessing that at the end of the decompression. So even as an orthopedic surgeon, I routinely use ultrasound to assess that patency after the laminectomy is done, and we can decide if we want to go a little bit more above and a little more below. So I think that, and Michael, I think made this point that surgical technique matters in the decompression of the spinal cord. And I think in the vast majority of cases, if you are thoughtful about this, then a duroplasty is probably not required.
Yeah, I would agree with Brian's comments. And I really like the use of intraoperative ultrasound. And I think surgical technique does matter. So validating that you've got a good decompression intraoperatively. And I do this also, you know, in the thoracic cord as well, even in so-called Asia A patients, because although the prognosis isn't as good, more of these patients convert than you think might. And then also trying to reduce chronic complications like syringomyelia, for example, by getting a good reduction. And to come to your point, we don't have a lot of tools that we as neurosurgeons, spine surgeons can use when we're in trouble with the spinal cord. So corticosteroids are a tool. So yes, I use them. And like, let's say if I'm doing a difficult tumor case, and let's say I've got some changes that are occurring, you know, there are a few things I do, like I'll take a pause, but I will often rebolus with corticosteroids. And I think it's an adjunct, to use. And so I would say, yes, I think that's a very kind of a valid, I think it's a valid approach. I think whether or not you're convinced by the data that show neurologic improvement, there are convincing data that in 2024, the medical risks are extremely low and can be managed very nicely. So that does not need to be, a concern.
Thank you.
And if there's time for one kind of other comment about the intraoperative spinal cord injury issue, and I think this is one of the things that we would encourage people to read the 3 papers that were published on this in the guidelines, is that, I think one of the important points that we want to make about this concept of intraoperative spinal cord injury is that this is something that everybody experiences. This is something that everybody encounters, and it doesn't, we think that it's important actually to destigmatize this issue of having an, experiencing neurological, decline around some of these very complicated cases. We all have them. We all undertake cases that are high risk. And I think it's important, the important part of one of these, particularly the diagnosis and definition of this, is to actually start to, I think within our spine surgery community, have an acceptance that, if you have an intraoperative spinal cord injury, this doesn't mean you're a bad surgeon. That this is something that happens. And so, having, an approach to managing it, being able to, talk about it, being able to, describe, what happens when this occurs is an important part of, I think, all of us striving to provide better care. But we do want to try to, change the discourse on it. It doesn't mean that you're a bad surgeon when this happens. It is something that does happen, and hopefully this will be a useful tool for the community.
Very well said, and I fully agree. And we're very hopeful that these documents will be of assistance to surgeons in their practice, and that they'll consider adopting some of the tools that we have proposed.
Yeah, I'm sure surgeons will. So we got one more question from the Q&A box. It's a question by Andreas Dimitriades, who asks, could you please comment a little on the place of guideline-driven spinal cord injury treatment in the place of polytrauma, especially concomitant craniospinal trauma?
That's a great question. And so, our guidelines in the strictest sense really apply to patients with an isolated spinal cord injury. In the setting of polytrauma, there's additional judgment that is required, and it may not be possible to always operate within 24 hours for very good reasons. If there is life-threatening hemorrhage and elsewhere, there is a significant traumatic brain injury, the diagnosis of a spinal cord injury can be challenging. And so having a high degree of sensitivity around, could you have a dual injury is going to be important. Having said that, I think the guidelines also indicate that spinal cord injury is an important topic, and that it does need to take a priority. There needs to be discussion around how this will, how this will be managed. And that does represent a shift over, say, 25 years ago, and it was, well, this isn't really that important and it can wait whenever. It is an important injury. It may need to take a second stage to deal with immediate life-threatening injuries. So there is a lot of judgment that is, that's required there. And Brian, how have you navigated that topic? It's a really important question.
Yeah, it's a very important question. And I think that, I think that the point we make to in our teams here is that, for the spinal cord injury component of their care, like that's actually something that, if you think, well, yeah, we got to fix their femur, or we got to, do something that's going to actually allow them to use their lower extremities, we do try to push for the importance of actually trying to address their neurological injury. And I think that, as Michael said at the beginning, there is a lot of judgment. I mean, obviously you need to have patients that are stable, that, to undergo the spinal fixation that you're proposing. But I think that, getting the message out there that there is something that we can actually be doing for the spinal cord, that there is something that, that we can, like, to having this sort of nihilistic attitude that, oh, there's nothing that can be done. I think that's, I think it's important to be able to communicate that within our care environments, and that, by really, emphasizing that by providing this care, by aggressively managing their hemodynamics, by addressing their surgical decompression, that we can actually do something to affect their downstream neurological outcome. I think this is an important message that we need to get out there to within our local environments.
Okay, Brian, Michael, thank you very much for this excellent presentation and the very helpful discussion for, I think, a lot of people for their daily practice, how to handle these cases. I think this is very, as the written guidelines, a very, very important thing. Thanks, Michael, for taking your time out of your outpatient clinics and being here tonight. Now for the rest of you, for discussing, thank you for your participation. Enjoy your summertime, enjoy your vacation, and we're going to be back with more in a spine section webinars after the summer break. Enjoy the rest of your day for you in Canada, and the evening for all European participants. Thank you. Bye-bye.
Thanks for having me.
Many thanks for allowing us to present. Really appreciate it. Thank you. Bye. Enjoy your summer.
Bye-bye.
Bye-bye. Bye-bye.